Hello everyone, I am Dr. Mythri Shankar from Bengaluru, India. In this session, I will be giving you an introduction to glomerular diseases. So here is the brief overview of my talk. I'll be talking about the syndromic approach to initial evaluation, the nephrology toolbox which is ever expanding and challenging, when and why to do kidney biopsy, and finally some summary comments. When we look at glomerular diseases, there are 5 syndromes which come under it. The acute nephritic syndrome, nephrotic syndrome, asymptomatic hematuria or asymptomatic proteinuria, rapidly progressive glomerulonephritis, and chronic glomerulonephritis. The presentation can be variable in glomerular diseases. It can be either renal limited or it can be accompanied by extrarenal manifestations. This can help us to direct the diagnostic workup. The evaluation may be either urgent or non-urgent. Like for example, if we are looking at rapidly progressive glomerulonephritis, then it is an emergency and the evaluation should be urgent. Sometimes the syndrome may be accompanied by the risks of complications. Like for example, someone with nephrotic syndrome may present with pulmonary embolism, which is actually a complication of nephrotic syndrome. Acute nephritic syndrome is a tetrad of hypertension, hematuria, edema, and oliguria. It usually presents a sudden onset of hematuria or proteinuria, often associated with bacterial or viral infection. There is a sudden decline in GFR, but usually this is modest, and rarely there is oliguria. Sometimes spontaneous remissions can occur. Hypertension is usually transient and it is volume dependent. The poster boy or the prototype of acute nephritic syndrome is post-streptococcal glomerulonephritis. Other common causes are infection-related glomerulonephritis, IgA dominant infection-related glomerulonephritis, IgA vasculitis, IgA nephropathy, C3 glomerulonephritis. When we look at rapidly progressive glomerulonephritis, there is a rapid and progressive decline in GFR within days to weeks, with some nephritic findings in urine analysis, often accompanied by oliguria. There is also extrarenal signs and symptoms usually seen. Hypertension is usually absent or mild. Rapidly progressive glomerulonephritis is an emergency and evaluation is urgent. We can classify rapidly progressive glomerulonephritis as type 1, type 2, and type 3. Under type 1, we have antiglomerular basal membrane disease. Under type 2, we have immune complex mediated diseases like cryoglobulinemia, lupus nephritis, IgA vasculitis. Under type 3, we have pauci-immune glomerulonephritis, like for example, ANCA-associated vasculitis. Nephrotic syndrome is a pentad of edema, hyperlipidemia, lipiduria, hypoalbuminemia, and proteinuria. Usually, nephrotic range proteinuria constitutes more than 3.5 grams of proteinuria per day. GFR is usually normal or sometimes variable. The common causes of nephrotic syndrome are minimal change disease, focal segmental glomerulonephritis, membranous nephropathy, C3 glomerulonephritis, particularly dense deposit disease, amyloidosis, diabetic nephropathy, and lupus nephritis. So clearly in asymptomatic hematuria or asymptomatic proteinuria or asymptomatic hematuria along with proteinuria, there are no symptoms. There might be persistent or intermittent, either visible or non-visible hematuria and non-nephrotic range proteinuria. GFR is usually normal or maybe slightly reduced. Hypertension may or may not be present. Usually extrarenal findings are absent, the common causes being IgA nephropathy, thin basement membrane disease, C3 glomerulonephritis, dense deposit disease, and Alport syndrome. Chronic glomerulonephritis presents as a slowly progressive decline in GFR accompanied by hematuria and proteinuria. Hypertension is usually variable but severe towards the later stages of glomerulonephritis. Any of the glomerular syndromes can evolve into chronic glomerulonephritis. The common causes are IgA nephropathy, focal segmental glomerulosclerosis, membranous nephropathy, Alport syndrome, C3 glomerulonephritis, dense deposit disease. The clinical syndromes gives us a clue to the pattern of evaluation. Presence of extrarenal signs and symptoms are usually suggestive of secondary renal disease rather than primary glomerular diseases. Family history, occupational, social history, intake of concurrent medications and comorbidities are important in evaluation. Like, for example, someone with Alport syndrome may be having a family history. Someone with an occupational exposure to silica may be at higher risk for ANCA-associated vasculitis or anti-GBM disease. Consumption of alternate forms of medications may put the patient at a higher risk for membranous nephropathy and so on. As I already mentioned, rapidly progressive glomerulonephritis is an emergency and evaluation is urgent. The causes of glomerulonephritis are broadly divided into 5: infection-related, autoimmune glomerular diseases, alloimmunity, autoinflammation, and monoclonal gammopathy. The nephrology toolbox is ever expanding and challenging. Now let's look at the nephrology toolbox. The bedrocks of the toolbox are urine analysis, proteinuria estimation, and estimated GFR. Repeated evaluation is often needed to determine the pace of change. Dipstick alone is never enough. It is very sensitive to albumin but not to globulins. Like, for example, in multiple myeloma, the dipstick may not pick up globulins present in the urine. It is very sensitive to hematuria, hemoglobinuria, and myoglobinuria. False positives are also very common. So if by chance we are looking at a positive blood by dipstick, it is very essential to do urine routine and microscopy and closely inspect the urine for sediments. Highly alkaline urine, contaminated urine, and presence of quaternary ammonium compounds may give false positivity in dipstick. If the urine is very dilute or if there are globulins, we may get a false negative for proteinuria in dipstick. Presence of more than 40% dysmorphic RBCs, more than 5% of acanthocytes, or even one RBC cast is suggestive of glomerular hematuria. Also, if you look at the total amount of protein that is excreted, if albumin comprises more than 50 to 60% of the total protein that is excreted, it is mostly favoring glomerular hematuria. The GFR is calculated by serum creatinine-based formulas such as CKD API formula. It is usually not very precise and requires a steady state condition. It overestimates the true GFR by about 20 to 30% in true nephrotic syndrome with hypoalbuminemia, and underestimates in very obese patients because of this issue of body surface area. If you're looking at the exact GFR measurement, then iohexol mediated plasma clearance will give us the precise value. So if you're looking at complement mediated glomerular diseases, we're going to ask for C3 levels, C4 levels, CH50 levels, anti-factor H antibody levels, C3 nephritic factor, and genetic workup. If the etiology is going to be autoimmune disease, then we're going to ask for ANA and the associated antibodies. If you're thinking of primary membranous nephropathy, we're going to ask for anti-PLAR antibody levels. And also in membranous nephropathy, we're going to ask for NEL1 and thrombospondin analysis. If the differential diagnosis is pointing towards viral associated etiology, you're going to ask for hepatitis B, hepatitis C, and HIV serology. And if any of these turns out to be positive, you're going to ask for viral load quantification. If the differential diagnosis includes monoclonal gammopathy of renal significance or paraproteinemia related glomerular disease, then we're going to ask for serum protein electrophoresis, urine protein electrophoresis, serum immune fixation analysis, urine immune fixation analysis, serum for free light chain assay. If the patient is having a strong family history, then we're going to ask for genetic testing. Sometimes urinary proteomics may aid in the diagnosis of glomerular diseases. It's important to look at the kidney size and to rule out any congenital anomalies of kidney and urinary tract. Very rarely CT or MRI may be needed. CT guided kidney biopsy or MRI guided kidney biopsy might be needed. Sometimes a non-kidney biopsy may give diagnosis such as skin biopsy or abdominal fat pad biopsy in cases of amyloidosis. Bone marrow examination suggestive of plasma cell dyscrasia may also give a diagnosis of paraprotein-related glomerular diseases. So if an elderly patient presents with rapidly progressive glomerulonephritis and pulmonary hemorrhage, we would suspect anti-GBM disease or post-immune glomerulonephritis, and hence we would ask for anti-MPO antibody levels or anti-PR3 and anti-GBM levels. If there is an older non-diabetic adult who presents with apparently primary nephrotic syndrome, then we are suspecting membranous nephropathy, and so we ask for anti-PLA2R antibody levels. If there is a young male who presents with glomerular hematuria, non-nephrotic proteinuria, we're usually looking at or suspecting C3 glomerulonephritis, and so C3 and C4 measurements are important. Now let's look at when and why to perform kidney biopsy. Kidney biopsy is a reasonably safe procedure that can yield a definitive diagnosis, provide useful therapeutic guidance, and prognostic information in selected cases. What are the indications for kidney biopsy? In patients with nephrotic syndrome, patients with rapidly progressive glomerulonephritis, patients with symptomless hematuria or proteinuria, when proteinuria is more than 1 gram per day. In some institutions, they even do biopsy when the proteinuria is more than 500 milligrams per day. Progressive chronic kidney disease when the cause is not clear, non-resolving acute kidney injury, and for identification of genetic glomerular diseases when the genetic analysis is usually not available or inconclusive. However, the indications for kidney biopsy may vary based on practice patterns. There are certain instances where kidney biopsy is not needed, like for example, in a typical case of post-streptococcal glomerulonephritis presenting as nephritic syndrome, a typical nephrotic syndrome in children under the age of 10 years and beyond the age of 2 years that are steroid responsive, in patients with the prior diagnosis of steroid responsive nephrotic syndrome who relapse but they remain steroid responsive, in adult patients believed to have primary nephrotic syndrome who are positive for anti-PLA2R antibody and have normal eGFR for their age. In patients with shrunken, atrophic, and advanced chronic kidney disease, kidney biopsy might be risky because of increased bleeding risk. Light microscopy, immunofluorescence, and electron microscopy should be performed on the kidney biopsy tissue whenever possible. Immunofluorescence is generally needed to diagnose IgA nephropathy, where we see mesangial IgA deposits. In anti-GBM, we see linear IgG deposits along the glomerular basement membrane. Granular deposits of IgG along the glomerular basement membrane is seen in membranous nephropathy. In C3GN, we see granular deposits of C3 along the glomerular basement membrane and also C3 deposits in the mesangium or in the subendothelial space. In ANCA vasculitis, we don't see any immune deposits, and so it is called as post-immune disease. In monoclonal gammopathy of renal significance, we usually see light chain restriction, and a full house pattern is suggestive of lupus nephritis. Electron microscopy is needed to diagnose minimal change disease, focal segmental glomerulosclerosis, Alport syndrome, thin basement membrane nephropathy, amyloidosis, monoclonal gammopathy of renal significance, C3 glomerulopathy, dense deposit disease, and Fabry's disease. So in summary, the evaluation of glomerular disease should proceed in a systematic, stepwise fashion, starting with the consideration of the syndromic presentation, modified by extrarenal symptoms and signs, presence of family history, occupational and social history, concurrent use of medications. Evaluation may be urgent in case of rapidly progressive glomerulonephritis or non-urgent. Urine analysis with examination of urinary sediment microscopically, assessment of proteinuria and GFR are the bedrocks of evaluation. The toolbox of lab tests should be utilized in a manner consistent with the clinical findings. Kidney biopsy in selected cases can provide very useful diagnostic, therapeutic, and prognostic information. Thank you.